Certainly. Let us pray. Oh God, we come right now, firstly, thanking you for all that you've done for us. In spite of all the many and myriad problems and issues that we have in this day, we thank you, God, for giving us the spirit of unity that we might search our hearts, search our consciousness, even search this society, God, that we might come up with ways to solve society's ills. We thank you, God, for all that you've done, and we pray that you would be with us during this discussion. This we ask in your holy name. Amen.
Amen. Thank you so much. So, welcome to Diversity Cafe. Today we have Reverend Johnson with us from Greater Harvest Church. And I had contacted Common Ground Health so that we could get someone to come in and just talk about health disparities as it's related to systemic or structural racism and even COVID. And so they said, well, we've got someone. His name is Reverend Johnson. And that is going to be our speaker for today. I know that Marc is also here. He is here. Hi, Marc. He is helping to support Mr. Johnson, Reverend Johnson here. So these will be our speakers today. And I'm going to let Reverend Johnson take it away.
Well, thank you. It's just an honor and a privilege to be here today. And so Marc and I, we're going to tag team today and do some things. I'm going to open up and have some discussion with you. And then Marc will come in a little bit later and go through some of the finer points of the data with you as well. And we will conclude with some overall discussion. But I do want to encourage you that if there are questions along the way, if there are comments, if there are concerns, don't let them sit idly. Let's have that discussion. And I'll try to remember to pause at certain times to open up that discussion. And so thank you for inviting us. It's an honor to be here. I'll give you a little bit about me very quickly. I am Sebrone Johnson. I serve as the senior pastor of the Greater Harvest Church on the city's northwest side. I also serve, when I have a little more time, as the senior vice president of operations of the Urban League. And one of the reasons I think I was asked to kind of come on here is because I serve as the co-chair of the African American Health Coalition with Common Ground Health. So those things kind of keep us a little busy, but we are so happy to have this discussion. So as Marc begins to kind of cue us up on our presentation, let me start by saying that it's not lost on me that today is June 19th. That today actually is the day that we celebrate Juneteenth. There have been a lot of events around the city, a lot of things that have gone on celebrating the day that individuals learned they were free. And so we celebrate the Emancipation Proclamation on June 19th. But I want to caution us that this is not really the day to celebrate when enslaved persons in this country were set free. We ought really be celebrating the day that they received the information that they were set free, because we know that the Emancipation Proclamation occurred January 1, 1863. But in Galveston, Texas, they did not get the news overall until June 19th, 1865. So 2.5 years after the enactment of that set enslaved people free, we didn't all learn of it. And I make note of that to let you know that information is key. If you really want freedom, then follow the data. Information is key. And so we want to look at the data that we hope will set some minds free, or at least get us on the pathway to begin the discussion. And so we're going to take a look at the devastating toll of racism and poverty on Black health, the absolute devastating toll of racism and poverty. And they are twin sisters. And so we need to understand that they go hand in hand, and we're going to bring those facts out a little bit later. But we hope that by taking a deep dive into systems and institutions that affect Black and Brown people in our communities, we might be able to strategize on ways to free all of our citizens from those devastating effects of racism and poverty. Martin Luther King Jr. said, of all the forms of inequality, educational inequality, housing inequality, political inequality, of all the forms, injustice in health is the most shocking and the most inhuman, because it's the one that results in physical death. That's the one you don't come back from. And so that tells us that we need to really look at the effects on our health and all the things that constitute poor health in order to fight inequality at its highest levels. Next slide. So we know that we are in the throes of COVID, and we know that COVID has wreaked havoc on us. I was told that we should never let a good crisis go to waste. And COVID is just the latest example of what we find out in every single crisis. We find out that those things that we tried to ignore, those things we swept under the rug, those things we said was not a major problem, those things that we said don't occur in a post-racial America, that it takes some form of a crisis, a pandemic, if you will, to shine the light on these things and say, no, they're still there. And so looking at this slide, African Americans and Latinos have faced much higher rates of COVID than their white counterparts. If you look at the case rate, Blacks have experienced COVID 43% higher in terms of rates than their white counterparts. And in our Hispanic community, 73% higher. And when you look at the hospitalization rate, a whopping 236% higher for Black Americans and 200% higher for Hispanics. And then, of course, with the death rate, that Black Americans are dying from COVID, 83% more than white counterparts, and Hispanic Americans dying at 90% higher rates than their white counterparts. So not only are Black and brown communities contracting COVID at higher rates, but once contracting it, it is exacerbated because they are hospitalized at much higher rates. And even after being hospitalized, they are dying at much higher rates. And so we have to take a look at what's behind all of this. Next slide. Structural inequities. This by now, we've all heard this stuff so much that this doesn't take a ton of reasoning to understand that where there are structural inequities, your risk factor goes up exponentially. And so one of the reasons that the case rates were so much higher is that there was a higher risk of COVID infection among Black and brown communities, particularly those that live in marginalized areas in society. Jobs where working from home isn't possible. That's the lay of the land for a lot of individuals living in urban environments, that they cannot work remotely. They cannot go in on Monday and Wednesday or Tuesday and Thursday, that they must show up in their jobs and work. We thought it wasn't a big problem that there was a lot of unskilled labor. We figured as long as you're getting a paycheck and one day you'll retire. No, but when a pandemic hits, you don't have the luxury of deciding to stay home and work. And there's a dependence on public transportation. If you're living in urban marginalized communities, you must take the bus, you must take Uber, you must take those forms of transportation to get anywhere. And you cannot enforce 6-foot rules in crowded buses. You can't demand that every Uber driver has properly sanitized their vehicle before you got in. And so this shows more disparity. And there's less opportunity for individuals in marginalized communities to be able to call the local grocery store and have them deliver their products at home. Obviously, the grocery store is not in most of these neighborhoods. And so it's not available to them. And of course, the neighborhoods themselves are so densely populated that there are many more encounters and interactions that always up the risk of getting COVID infection. But for those who are infected with COVID, there's a higher risk of complications. They're more likely to have chronic conditions because of structural barriers to staying healthy. It's one thing to say, eat your fruits and your vegetables. But if there are no supermarkets in your area that sells fruits and vegetables, and those that do sell them at exorbitant rates, and so you can't even afford to stay healthy, you find yourself relying on canned goods and dried goods, and it takes a toll on your health. They're less likely to have access to testing for early detection. We tried to do a lot. Common Ground certainly was forefront in the effort to trying to bring the tests to every neighborhood possible. But the truth of the matter is that the situation, the disparity is so vast that when we tried to have testing everywhere, it was not available for everybody. Dome arenas, not everyone can make it to those places. And two, sites that are located from 9 to 5 don't really help communities that have to work from 9 to 5. And obviously there's the trust factor. And so there's a complication there. And then lastly, they're less likely to have access to care to manage their systems. It's a shame, but for so many, the primary care physician is the emergency room. And so preventative care is not the measure of the day. And so individuals who contracted COVID, especially in the early months, they were very symptomatic and almost to the point of not being able to walk before they went to the doctors to see what was wrong. And there wasn't enough information, and so many were sick. But they didn't get information. They didn't have early access, and immune systems were already compromised. And so there were further complications once COVID was contracted. Next, Mark. So health disparities have always, I wish that was in capital, always existed for the African-American community. COVID-19 is simply shining a bright light on how unacceptable that is. Dr. Anthony Fauci said that earlier in 2020, that these conditions have always existed. And I have to emphasize that it is not 2020 or 2021 when Black Americans decided to say we need more grocery stores in our neighborhoods. We need more healthcare facilities in our neighborhoods. We need access to more banks in our neighborhoods. We need better housing in our neighborhoods. We need more playgrounds in our neighborhoods. This is not a new issue, but COVID has brought this thing to the forefront. And now we see the devastating effects that trickle down through all areas of life simply because we did not pay attention to the call, the clarion call of individuals. And so we want to take a look at those things that really do determine your health. Next slide. We're going to talk about something called the social determinants of health. And the World Health Organization defines health inequities in this way. The WHO says health inequities are differences in health status or in the distribution of health resources between different population groups. Let me emphasize this next part, Mark. It says that it arises from the social conditions in which people are born, grow, live, work, and age. Simply put, the World Health Organization is telling you something that we now know to be true, that I know more about your health. I can tell more about your health from your zip code than I can from your DNA. That the social determinants of health and the health inequities that exist will really determine to a large degree where your health will go. Next slide, Mark. And so take a look at this. When we look at health outcomes, we find that the social determinants of health really are the important factors. 40% of your health is determined by socioeconomic factors. Among the factors are education, job status, your family or social support, your income, and community safety. 40% of your health can be determined and predicted based on where you go to school, where you work, and how much you're getting paid, by the way, the support system in terms of family and friends that are around you, the wealth or income brought into your home, and the overall safety, including policing, around your environment. 40% of your health can be predicted based on that. 10%, another 10% based on your physical environment. That's a zip code. Another 10% just based on where you live says so much about your health. Now, these things are obviously include your water, your air, pollution, those types of things, but it also includes the stress level based on where you live as well. It also deals with your ability to be able to play, your ability to have healthy conversations, how it affects your mental status. Physical environment, 10%. Another 30% based on health behaviors. Let me look at 1 and 3: tobacco use and alcohol use. We all should be shouting murder on these things, because while we cannot find enough banks, while we cannot find enough healthcare facilities, we cannot find enough grocery stores in many urban communities, almost every corner has a store that will sell you cigarettes. Almost every corner has a liquor store that will sell you alcohol. And so there's easy access to tobacco and alcohol, not so easy when it comes to healthy foods and healthy living. And of course, another health behavior, diet and exercise. It's linked to some of the previous things, but when you work all the time, when you don't have access to stores, then your diet and your ability to exercise, when you don't feel safe walking around your block, then the ability to exercise is hampered. And linked in there, sexual activity, when you don't have access to real data, when you don't have access to real information and the dangers of wanton sexual activity, it becomes a determining factor in your health. And then lastly, where we began earlier, healthcare, 20% of your health is determined based on the fact that you don't have access to quality healthcare. Now, let me pause for a second here. When I say access to quality healthcare, there's 2 things we want to think about. On the one hand, what I mentioned earlier is that we really do need to have healthcare facilities that are accessible to urban and marginalized communities. But we also, and this is true for all Black and Brown individuals, we also need to have access to quality care once we are inside those institutions. A personal story, maybe 2 or 3 months ago, I went in for a checkup and a concern that I had. I have a son that's in first year college, and he plays on the football team. And so one of the things they ask us to do is to help them work out, make sure they meet their goals. And so I was helping him work out, and foolishly didn't realize I can't lift like I used to lift. And so I strained my back pretty good. And I went to the doctor for physical and to talk about my back. And there was a replacement physician. And when she talked to me, she let me know she was very informed. She had charts that detailed the risk factors of Black Americans with respect to heart disease, high blood pressure, stroke, diabetes. And so we talked about those things ad nauseum. She suggested some things I needed to do and some things I needed to be aware of. They took so much time with me in talking about these risk factors. An hour later, she said, well, I hope to see you in about 3 months. I said, I hope so too, but I came about my back. And so it's interesting that sometimes we can get so caught up into statistics that you don't see the individual. I have a back problem, and I needed to talk about my back. And so that also is an issue in terms of healthcare. Do you see the person, or do you only see a number? Do you see a person, or do you only see skin color? And so even under the guise of being very informed, it didn't apply to me as an individual because I wasn't being heard. Health outcomes are determined by these determinants, these social determinants of health. Next slide, Mark. And so we've discovered that poverty and racism undermine the social determinants of health. Let me give you these 5 areas: your economic stability, the neighborhood and the built environment around you, your education access and the quality of that education and access, social and community context, healthcare access, and quality. Do you know what's at the center of all those things? Poverty is what drives inequalities and inequities in these areas. Poverty is at the root cause of the disparities of these social determinants of health. And if we can deal with the poverty question, we'll be able to deal better with these social determinants of health. And what's behind poverty? Racism. People aren't poor simply because they were born poor. People aren't blocked out of access to better care simply because of their last names. They're blocked out because of institutions of racism that lock them out, rather known or unknown, rather intentional or unintentional. These systems create wealth disparities and care disparities that create more disparity in terms of health outcomes. And so we cannot ignore the poverty question. We cannot ignore the race question if we're ever going to tackle these social determinants of health. Now, I want to pause right there and ask Marc to begin a conversation on the next part of this. But I want to pause and ask, are there any questions or areas that we need to illuminate at this point?
Not for me, but I will say there were things that you said that I didn't know, so, or hadn't really thought through. So I appreciate it.
Thank you.
Yes,
Excellent.
just wondering, Reverend, what impact does the healthcare system itself, I'm thinking of like the, in general, but the hospitalization, you mentioned that for many people, many minorities, the only primary care physician is the emergency room. And so I'm wondering, is it built in within the healthcare system that if you come in and you happen to be on Medicaid, you get less care? Is there statistics to prove that?
And I'll let Marc talk a little bit, but I think what we'll find is this, that when I say minority populations and access, I'm talking specifically about marginalized communities in which there are no healthcare systems in close proximity for individuals to be able to get to. Those who have greater wealth access tend, even in minority situations, tend to be able to at least get routine healthcare. I think your question goes more to, but once you're there and you see a doctor, do they look at the type of insurance that you have? Does it become an economic question or a social status question? And does that determine the kind of healthcare you get? I would say this. I would say, and Marc's going to get to this part a little bit later, but I would say absolutely, because there are humans that treat you. There are humans that judge you. There are humans that size you up in the first 5 minutes that they talk with you, that process that benefits card that you have. And so while I'm not so sure that the system itself says, if you're on Medicare, Medicaid, Medicare, you must get worse care, I do believe that individuals make those judgment calls. And beyond the insurance that you have, I think also, and data does prove this out, that when they make those judgment calls, some of that is based on bad science. Bad science has determined in some cases that Black skin is thicker than white skin. And so black, and this is science. I'm not talking about just individuals, medical science. And so Black people have higher tolerance for pain than white people, and therefore routinely Black people are under medicated for conditions, for situations that would call for them to have greater comfort, because they believed that black persons really could take more pain. And so it's not just that the system says this is how it is. It's sometimes science and ignorance in science has proven faulty. And that's why we have to stay up to date with all of these things. Mark, you have something to say on that?
Yeah, I think so there's been quite a bit of research and I was going to cite some of it later, that's shown that even in kind of recent history, Black patients routinely get less, they have access to fewer procedures, fewer medications, and lower quality care. And I think that gets a bit to the point that Reverend Johnson's talking about. There's data behind that, specifically with regards to kind of Medicaid and its the coverage and implications there. One of the analyses we did, and this is local data, so for our region, we found that for hypertensive patients, whose condition can be typically quite well managed with the right medication, we found that equivalent group of patients with Medicaid coverage consistently had much less access to the medication that they need than patients with commercial policies. And one of the reasons we believe for that is the way Medicaid policy is written is it basically requires you can, I think for most things, only get a prescription for 30 days. And so that means if you're on Medicaid, every 30 days, you need to pick up your medication and deal with that processing. Whereas with a lot of commercial policies, I think 90 days is more typical. So that's an example of a policy that is probably well-intended in some ways, but certainly has a disparate impact. And by the way, while there's nothing racial in how that policy is written, it absolutely has a racially discriminatory impact because more Black and brown people are more likely to be on Medicaid. So I think that's a good example of when, and I'll talk more about this, but when we talk about racism, in some ways, some of the most insidious impacts of racism aren't things that are explicit or necessarily even intended to be, have a racial impact, but they do because people just haven't fully thought through how this plays out for people in different communities and circumstances.
And Mark, I would say in that community also that doesn't get a lot of attention as far as the Medicaid question is concerned. Remember, so many individuals with developmental disabilities are also covered under the Medicaid clauses. And so in many cases, they cannot adequately represent what they need. And so, yeah, there can be discriminatory policies, which leads us to a thought later. Let's talk about this. But there's not only social determinants of health, but I wonder if we might talk sometime about the political determinants of health and how the political actions and policies affect Black, brown people and individuals who are underrepresented.
Any other thoughts or questions before I click ahead here?
I have a thought about Medicaid, just what you're saying about the 30 days versus 90 days or whatever. There's an inherent assumption there that people are trying to get something they don't need. And I also think, as far as in reference to the Reverend's conversation about Black and brown people, not being treated for pain appropriately, there's an inherent assumption there that they are drug seeking, that it's drug seeking behavior. So that's all I have to say.
I think that's right. There are assumptions built in, I think, both at a individual level, and so and a lot of the policies are written with those intentions or biases behind them. So I actually realized I don't know how familiar any of you are with Common Ground Health. So I thought just before I show more data, because that's kind of what I do, I just would just briefly mention why I'm here and how I and Common Ground Health is supporting the work that Reverend Johnson and the African American Health Coalition do. Common Ground Health is we're a local nonprofit organization focused on community health issues. And in these days, I'd say a huge portion of our focus is on health equity issues specifically. We bring together community-based organizations, county health departments, folks from the health systems and the health insurance payers. So we really bring everyone together to understand and talk about the issues that face the community. I think common ground, I mean, there's the reason we picked that for our name, and we really try to find the common ground and a path forward. And a lot of those conversations are really driven by the research and analysis that we do so that we can have a fact-based conversation that then helps focus everyone on the right issues. And so I am one of the research analysts in that group, and that's how I'm supporting these efforts. What I was going to do is talk in a little bit more detail about how poverty impacts health, and then how racism not only creates and exacerbates poverty and all of its impacts on health, but how racism itself creates additional layers of health impact beyond what we see and expect from poverty itself. So I'm going to start with a map. The blobs here are actually zip codes in our region. This is a 9-county region. For those who are familiar, you'll see Monroe County in the upper left. The dark area is Rochester. And in general, the darker areas on this map are those zip codes with the lowest socioeconomic status. And it's a metric based on income and poverty rates and employment rates and home ownership. But it's basically indicating those dark areas are those where more of the residents are living in poverty or just low socioeconomic conditions. And what you see across the region is, not surprisingly, you see very dark splotch up here in Rochester in the upper left. Elmira, one of the other primary urban areas in the lower right, is also very low socioeconomic status. But you see poverty is really spread across the region. And I think one thing that we at Common Ground Health are trying to do is spotlight that poverty is an issue across our region. It's concentrated in some of our urban areas, certainly Rochester, but it's not unique there. And what we find when you compare this to this next map, which is again zip codes, this map is showing those areas with the highest premature mortality rates. So those darker areas are the zip codes where more people are dying early and more people are dying at a younger age. And the key point here is that there's really not much difference between those maps at all. And I think this is a striking kind of geographic way to see that not only is poverty and its health impacts very clearly connected, but this is an issue for our whole, that spreads across our whole region. And when we talk about the impact of poverty on health, it's not just people dying early, it's also about quality of life. And when we look at the types of physical health conditions that folks are more likely to have, and I think Reverend Johnson made this point earlier, pretty much any health metric you look at is worse for folks with lower incomes and lower socioeconomic status. So whether it's dental issues, basically folks in the lowest socioeconomic areas are 105% more likely. That's more than double to need to have teeth removed. Diabetes rates, asthma rates, and this list would go on forever if I included everything. Pretty much every health condition is significantly worse for those folks in poverty, or just in general people with lower incomes and access to fewer resources. And importantly, this isn't just about physical health. Mental health is impacted probably at least as much And importantly, I'd say there's a big connection, and I'll speak to this in a moment, a big connection between mental health and physical health. But we did a survey of folks across the region. We spoke to almost 7,000 people across the region and collected a lot of really interesting and useful data. And people told us about their situations and their health conditions. And what we found is that folks with the lowest incomes were 3 to 4 times more likely to have these types of feelings of helplessness or anger or self-destructive behavior. And by the way, the rates are much higher also when we looked at things like depression and anxiety. But putting aside clinical diagnoses and just thinking about how people are feeling in their day-to-day life and how these sorts of feelings impact their actions and how they engage with their life and their family and their community, these impacts are huge.
Okay, can I ask a question?
Yeah, please.
All right, I'll turn my video on so I'm not always invisible. Do you know anything about the statistics of any of the countries that have whatever kind of healthcare it's called, where everybody has the same healthcare? Like, does poverty affect people as badly if healthcare is the same for everyone or not? Do you know?
Not directly. So that's a really good question. And I do not know offhand. I will look afterwards to see if there's been research done there. But what I would say more generally, and this isn't the exact question you're asking, is that when you look at countries that have more universal health care coverage, you do generally see more equitable outcomes. And I think something that's been unique in the United States, I forget the exact, I feel it's like 2014 to 16 or so, for the first time in 100 years, our country saw a decline in the average life expectancy of our citizens overall. And that was unique in American history, and I think that's unique across all developed countries. And it was completely driven along socioeconomic lines. And a lot of that has to do with the deaths of despair. I don't know if you folks have heard the term, but which comes back to mental health.
So does that mean then that for the first time in our history, we have a higher rate of poverty than I'm saying that wrong, but our poverty is increasing and therefore our health, our death rates are increasing? Is that the right way to say it?
No, well, so what's interesting, and this is going to quickly get beyond my depth on this issue specifically, but I do know it's actually not that poverty rates have necessarily gotten worse or necessarily got worse over time. It's that the connection, that the impact of poverty on mental health and the impact of poverty ultimately on lifespan, that connection has gotten deeper. Not necessarily that poverty itself has gone up. I do think there's areas where poverty rates have gone up, but that's a different point.
Okay.
And I think it gets to some of the things that the Reverend was saying, and I'm trying to add some color to that, because of the way that not just the healthcare systems, but the way that the social determinants of health work in our country. If you're in poverty, if you don't have access to the resources to take care of yourself, to give you the choices that make it possible to live a healthy life, it shows up in both your physical and mental health.
And Marc, I think it's probably important to Cindy's point of wondering why the age has come down, and so now we're dying earlier. Remember, that's an average across the entire lifespan, and one of the factors there is the mortality rate of Black women dying during birth, during the birth of their child, and so that is happening at really big rates, where Black women are dying more than their counterparts, and that factors into that.
Wow.
Yeah.
That's really, wow. That's really shocking.
Yeah.
To me. Okay. Thank you, guys. I had no idea about that.
Yeah, no, there's a lot of unfortunately shocking statistics when you dig in.
Yeah, that's probably the last thing I would have guessed as far as why. I mean, those are young women. Oh, so I'm sorry. I'm going to be quiet, but that's really shocking.
No, and I appreciate the questions and discussion, because this will hopefully be more illuminating and enjoyable for all of us if we have discussion along the way here. So please interrupt, anyone with thoughts or questions.
Mark, yeah, and that is that's those statistics that you're citing is pre-COVID. It will be interesting to see what the mental state, how the COVID situation impacts everything, and when they can get the statisticians can get that information together and get it out to the public. But I don't imagine it's going to increase the lifespan of the human population.
No, absolutely. And I think, and also importantly, much of the, early indicators that we've seen, both in terms of COVID's direct impact on life and death rate, some of the statistics Reverend Johnson shared, but also mental health, those are tending to exacerbate the inequities that already exist. So not only are things worse in general for everyone, but they're more worse for the folks that have, people of color and generally people more vulnerable, folks in poverty, that have always been at more risk, which is doubly sad. I want to, oh, sorry, go ahead.
I don't know if we want to take this up now. I'm going to throw it out there and just say, it'd be fine to talk about this at the end, but we brought up the fact about needing grocery stores, healthy foods in neighborhoods, economics. So this is not exactly new news, but it has definitely been more dramatized because of COVID. And we see these statistics over and over again. But the big question is, if we know these things, what kind of economic or initiatives are taking place to turn this situation around? And what I'm getting at is, it doesn't even matter who the mayor is or whatever. The big announcements tend to be how they're doing something to make the city more beautiful, whether it's the Genesee front or whether they're going to have a nice plaza in a rebuilt area. But as far as the systemic issues, and when we talk about grocery stores or whatever, there's no change there. We're not getting to where are the initiatives? What can we do as a group to ignite people to rally around this, to raise funds or whatever, to start building grocery stores in those communities, building businesses where there's economic opportunity, and start innovating?
Yeah, I would, so that's a great question. And I think ultimately where I hope this conversation goes,
Right.
My thought would be, because that could be a deep and I think really important conversation. If you could hold that thought, I'm hoping that some of the other information that I share will provide some additional foundation to inform the conversation we have around that. But I'm hoping we could discuss that a bunch, because ultimately I think what you're posing is the right question. Like, most of the data we're sharing here, it may be new to some of you, but the fact is this isn't new. These are issues that have existed, and they're not easy to solve. So what do we do about it?
Yeah, I realize it probably was a better question for the end, but I wanted to put it out there just so it didn't slide by. So make sure we have that discussion.
I'm glad you did bring that up, because That's what I want us all to keep on our mind as Marc's going through, because ultimately that's where we want to go. And we don't want to let that piece evade us. So I'm glad you brought it up now so we can have that in the backs of our minds throughout the presentation.
So, so in some ways, let's see if some of the other information I share helps, again, paint more of a picture of what both the obstacles and challenges are in moving towards what you're describing. So I think what's really important to understand when it comes to poverty, and I'll say the same thing about racism, is that the impacts, these are layers, and it's just like layers and layers of stress and disadvantage that cumulatively have such a toll. And so when we look at mental health, this is the survey I referenced earlier, when we just look at folks across the region and we look at sort of the people who have an adequate income, who live in what they consider a safe neighborhood, people who don't, who have no problem getting transportation for food, about 10% of people say that they'd assess their mental health as being fair or poor. When we now layer in, okay, now let's look at folks who report lower incomes, but they still live in a safe neighborhood, have transportation for food. Now all of a sudden we're up to nearly 1 in 4, a quarter of folks report having poor mental health. As you now layer in, and again, this is the layering effect that's so devastating of poverty, and again, I think racism acts in similar ways. It's like layers of stress and barriers. You see that the rates of poor mental health just jump up, and once you're burdened with these multiple layers or stressors, now more than half of adults report poor mental health. And I think this is just illustrative of how these affect, it's not just you face one barrier or stress, it's the cumulative toll of these conditions. And along those lines, I'll go kind of quickly through this, but this I think is important for understanding also the connection between mental and physical health conditions. When we think about these layers of toxic stress, that come from poverty. So it's insecurity about, am I going to have a roof over my head and for my family? I have food on the table, job insecurity. You think about historical trauma that folks have experienced. And again, I think racism adds a whole nother layer on each of these dimensions. But there's multiple proven ways that researchers have found that this leads to poor mental and physical health outcomes. So perhaps the easiest to understand is that these kinds of stressors have a real social emotional impact, feelings of depression, anxiety, hopelessness, and just apathy. There's also a real cognitive impact. And what this means is when your mind is full of just dealing with the immediate everyday stressors of getting through the day, it's harder to really have the capacity or time or to sort of energy to think through things that aren't urgent and aren't a matter of surviving the day. This showed up, I think, interestingly in the survey we did, where we asked people what their biggest concern about their own health and well-being was. And this is specifically for people in the 50 to 64-year-old age group. When you look at the right side, what people said, so these are people with household income over 75K, not surprisingly, the thing on the top of the list was aging. So people 50, 64, I'm now in that group, I can appreciate this some days. I am concerned about, as I get older, what's that going to mean for my health and just my well-being in general. What's really interesting, you ask people the same age with low incomes what their biggest concerns are about. And again, the question was your biggest concern about your health and well-being. The top concern was financial security. And I think this is telling because it shows that people are, when you're worried about the day-to-day and all those, those stressors that we've talked about, you're not worried about next year or 5 years or 10 years from now. You're not worried about necessarily those things that are going to pay off in 5 or 10 years. You're worried about the here and now and just getting through the day and the week. Um, yeah, and then finally, there's been a lot of interesting research that shows that these types of stress, and this type of stress is, by the way, different. Research have shown it's different than the type of stress that, I know I feel some days when I've just got like a busy workload and I'm stressed by it. These types of chronic toxic stress they actually have a physiological impact on your brain and the way your DNA evolves, and it has a real wear and tear on your body and brain. So stress isn't just something that makes you feel yucky or down or stressed. I mean, this stuff really impacts your health in all these ways. Some of them directly impact your health, your physical health, but all of these things also make it really hard. And this goes back to the healthy behaviors thing that Reverend Johnson mentioned. I think 30% of health is driven by health-related behaviors. And what I really want to call out is that at times it's tempting, and some people ascribe those behaviors to personal choice. And certainly there is, people can make good choices or bad choices. But the important thing to understand is when you're facing these types of stresses, these social emotional impacts, the impact on just how you're able to think, especially for the long term, the wear and tear on your body, like, and many of these folks live in neighborhoods where they don't have access to all the same choices as some of us do. Like if I'm stressed and out of time for the day, I have the luxury of hopping in my car, running to Wegmans and getting, a relatively healthy choice I could make in terms of a quick lunch. Not everyone has that luxury, and this combination of stressors, access to limited resources, it really limits the universe of choices that people can make, and it leads to more unhealthy behaviors. So I was going to switch gears and talk a little bit about how racism layers on top of poverty, but any questions or thoughts on this so far?
Yes, Mark, just a thought on the healthy choice issue. I think a lot of it also has to do with education. And with a lot of the minorities, they're living in single parent homes, or sometimes not even with the adults might be grandparents or whatever, but aunts or uncles. But you think of the younger kids, if you offered them, because of their experience and what they've experienced so far in life, which has been probably pretty rugged and tough, if you offered them an apple or a bag of chips, what do you think they're going to choose? Mm-hmm. So it's systemic, that it's a lack of sometimes education.
I think, just from my own personal view, I think that some of it is education, but I think that a lot more of it is just inherent in how society has normalized itself. And the reason that I say that is because if you drive down, and I noticed this, so I used to drive for Uber and Lyft, and a lot of my rides would always be like in Canandaigua or far out. And what I noticed as I was driving down these streets, I was like, man, there's not a McDonald's anywhere, right? Driving down all these residential neighborhoods, there's no McDonald's, there's no corner stores, there's no liquor stores in the suburbs, right? But you go to the city, there's a Burger King, a McDonald's, an Arby's, and any kind of fast food place that are not in shopping districts, right? There's a liquor store, like Reverend Johnson said, almost on every block, right? All of these things are readily accessible in urban cities or urban neighborhoods where the majority are Black and brown people. It doesn't have to be a shopping district, but you only find those kinds of places in shopping districts when you go in the suburbs. So of course, if I offer my son an apple or a bag of chips, he's going for the bag of chips because that's what he does. He's a kid. But also because that's what's readily accessible to him, no matter where he goes in the city of Rochester, in the urban neighborhoods, that's what's accessible, right? So even like when the farmers markets and the mobile markets, they start to come into the city, and you can double your SNAP benefits by buying these fruits and vegetables fresh. They're exorbitantly expensive. I would choose, if I was somebody that needed to use my SNAP card to buy something, I would readily go to McDonald's and buy a meal at McDonald's, because it's cheaper to feed my whole family McDonald's than it is to go buy a little bit of fruit that'll last me maybe a day. It's expensive to eat healthy. It's way more expensive to buy apples and oranges than it is to buy a meal at McDonald's. And that's a problem. We don't have access to it. And when we do have access to it, we've got to pay an arm and a leg. Sometimes people can't afford that. So they will choose the easier McDonald's or Wendy's, which is 5 for $5 or 4 for $4, whatever it is. Like, they're going to choose the cheaper meal, even though it's unhealthy, because that's what's it's going to leave them more money left over. But buy apples and oranges and celery and cucumbers and, vegetables fresh, that's going to take almost all of your income, all the income that you have allotted for food. That's not going to last you tomorrow. That might feed you today. It's not going to last you for the rest of the week. And imagine people with a household of 5.
So it comes back down to poverty
It
again.
comes back down to poverty.
It does come back down to poverty. And Candyce, I would say, based on your narrative, that shows why that there really is no healthy choice. Johnny is not choosing chips over an apple. There's no apple. There is no apple. And so he's taking what there is to eat. And I know I am exaggerating a little bit here, but I'm just trying to state how poverty and sustained poverty affects choice to the point where there is no choice.
I also think when I look at this slide, one of the main problems, I used to work for temporary assistance, and transportation is a huge issue. If people could get somewhere, they would go somewhere, but they can't. Either, if you're on temporary assistance, the bus passes, they treat them like they're made of gold. If you want a bus pass, you might as well be robbing a jewelry store. And so even getting one in the first place, but then after you have one, getting anywhere efficiently is extremely difficult. And I really don't understand why we, as a society, have chosen to make that such a scarce resource, but it affects people's ability to go get help or go get food quickly. Like Marc, I think you were saying you could jump in the car and go to Wegmans. People can't do that. So it's huge.
Yep. True.
So I'm going to shift gears a little, although this is all just building upon itself, to talk about specifically about racism, because what we've been talking about is poverty, and what's important to understand is that Blacks and Latinos, and this is in our region, are 3 times more likely to live in poverty. So the things we've been talking about aren't unique to communities of color, but they are much more, much bigger common problems, for Black and brown communities in our region. And why? I think, as a reference said earlier, racism explains why it's 3 times the rates, and I'll speak to that a little. But I know that this group is understands a lot of the history and the current realities of racism. One thing I want to show is that this isn't just about poverty, though. What this chart shows is again, it's showing premature mortality rates. So this is the same kind of information I showed on those maps earlier. It's a different way of showing that. On the left, you have those areas with the lowest socioeconomic status. So think the left side is low income, high poverty rate, and on the right you have higher income, low poverty rates. And what you see, which we've already spoken to, is those high poverty, low income areas have much higher rates of premature mortality. But here's kind of the kicker, is that if we now separate, look at the white and Black population separately, regardless of socioeconomic status, at every level, Black people have a much higher rate of premature mortality. And so the thing I want to call out here is, because this is how racism is, its impact on health truly is so devastating, is not only does racism lead to more people of color being in poverty, regardless of whether you're in poverty or not, you're still suffering significantly worse health outcomes. And this spans, spans the socioeconomic spectrum, and we'll talk a little bit about why in a moment. And by the way, I think, as we've said with other things, this is not unique to premature mortality or deaths. This is about, pretty much any health metric you look at is worse. Here's just, a sampling. African Americans in our region, the Finger Lakes, nearly 6 times as likely, all of these are compared to the white population. And I should say, all of these statistics are adjusted for kind of age and sex population differences to make them more of an apples to apples comparison. African Americans are nearly 6 times as likely to wind up in the emergency room due to asthma. Same thing for hypertension. More than 3 times as likely to have an infant die. I don't have the statistic up here, but I think it's also about 3 times higher rates of maternal mortality, as Reverend Johnson was saying. And the rates of Black maternal mortality in our country are similar to developing countries around the world. I mean, there's been just frightening studies to show how horrible those outcomes are. And mental health is worse as well. So again, whatever metric you want to look at, you see that racism impacts health above and beyond what we know we would expect just because of poverty. And again, I want to emphasize this a little bit. I think Reverend Johnson spoke to this too. But while the immediate causes and disparities in hypertension and infant mortality and mental health, they may seem to be very different, they're all largely rooted again in the same underlying issues, these social determinants of health. And I think you can't understand the outcomes we see without coming back to this model and seeing how racism leads to poverty, which impacts all of these factors in health, and racism on top of that has additional insidious effects on access to health, barriers to taking care of oneself, stressors, above and beyond what poverty alone would say. I think I touched on this before, but I think this is really important to call out, that as we talk about racism, racism isn't just about explicit discriminatory words or actions. I mean, unfortunately, there are still some of that. But this is also, and in some ways even more importantly, about deeply embedded beliefs, policies, and practices that lead to disparate outcomes for people of color. And it's often these hidden or even unintentional forms of racism that have the worst impact. And it's the example I was going to give, actually the Reverend already touched on a little. You think about COVID in the Dome Arena. So for a lot of reasons, I would say it kind of made sense to set up initial distribution of the vaccine at a couple of big sites like the Dome Arena. As it feels like a while ago now, but if you remember, all the initial signups had to be done through this online system, which was quite an adventure to navigate. I had my own experience with that.
Horrible.
And here's the thing, like I'm not, I mean, like I would not, I'm glad I'm not the person who was in charge of that. So like I realize, I'm not pointing fingers at anyone, but I'm just giving an example of how even well-intentioned folks can lead to racially disparate outcomes. So, here's an example where you think that, all of us had our challenges with it, but when you think about many of the communities of color, people, especially in the urban areas who are working these essential jobs, gaps in online access, gaps in able to spend 45 minutes or more trying to schedule an appointment, transportation to the Dome Arena, being able to get time off of, a job where you don't have that flexibility to pick your hours or work from home. These are all factors where, again, a policy that on the surface, there's no references to race when they developed that plan to use the Dome Arena, but without really thinking it through and actively taking steps to ensure that it has fair outcomes. I mean, you call it like an anti-racist approach to developing that program or policy. Without actively thinking that through, you wind up with, racially disparate, or, I'll call it, a racist outcome. And again, it not intentional, but that's what happens over and over and over again.
Mark, one other thought, and I was talking with my local librarian the other day, but many minorities depended on the public library, the internet access at the public library. They were closed.
Yeah.
So how do you get online?
Exactly. We are, so in about 2 weeks, we're publishing a report that goes deeper on all these issues than we're covering here today. The report's going to be called The Color of Health. We at Common Ground Health have developed it in partnership with the African American Health Coalition. So soon you'll be able to access that. But a framework we use, which we borrowed from the work that Reggie did, the Racial Equity and Justice Initiative, which the Urban League has now picked up to manage, is looking at these 4 levels of racism. And I'm not going to go through them all in detail now. But what I will call out is, again, it's this idea that it's like layers of impact. And so, at the most personal level, there's this concept of internalized racism, where folks have basically absorbed these beliefs about themselves and their potential. And internalized racism creates stress that it increases it erodes your mental and physical health. It increases the chances of unhealthy coping mechanisms. And internalized racism, it's that most personal, internal aspect of racism that impacts health in certain ways. And then at the broadest level, structural racism ensures the persistence of wealth inequity and segregation, all those factors that really drive the resources that one either can or can't access. And I think access to food and transportation are perfect examples of that. So it's these layers of effects that add up. I'm not going to go in depth on a lot of these, but I want to talk about a couple issues specifically, because I think they're really important and good examples. So one of the most insidious forms of institutional racism is housing segregation. I'm guessing folks have seen the map on the left before. This is from the mid 1930s. I mean, this was federal policy determining where lending was and wasn't possible. And it basically prevented people of color from getting access to home loans, which we all know is critical, not just to short-term housing, but wealth building over the long term. And when you look at this map from 1935 and compare it with this map from 2017, the green areas are those neighborhoods with high poverty and high concentration of, and at least half the population is Black and brown populations. It's basically the same areas. And so the point is, we can, I think some folks take comfort or point to the fact that, redlining, segregation is a thing of the past. But first of all, while the explicit policies are, there is still a lot of evidence that through more informal and subtle steering and decision-making by real estate and lending companies, segregation is still very much enforced, if not informally, by those industries. And the fact is, like, its effects are very long lasting, and we see that today. And housing is so important, not just because it's, you know, your home, but housing is central to determining, you know, so many of the resources that are critical to health and well-being. Where you live, your neighborhood, determines schools, determines what jobs you can easily access, you know, whether there's grocery stores nearby. We've talked about that. You know, healthcare and other public services. And again, like, housing is how the white population built up wealth over the last, you know, few generations, and you know, federal policies basically prevented most people of color from, you know, from participating in that wealth building, you know, over the last 70, 80 years. One way this shows up, again, I'm trying to make the distinction, you know, we've talked a lot about poverty, which impacts people regardless of color, but I really want to, you know, I think this is data that helps clarify how, you know, being poor and white is not the same as being poor and Black. So what this data shows is the numbers are the percent of households that live in neighborhoods that are deemed high deprivation neighborhoods. So these are neighborhoods with high rates of poverty, you know, few resources like healthy, you know, like grocery stores and you know, health centers. A lot of these metrics that you'd expect. When you look at where the low-income white households live, so the under 25K white households, so this is the lower left of the chart, you see 25% of low-income white households live in these highly deprived neighborhoods. When you look at low-income Black households, which is the 77% number in the upper left, it's 77%. So we may be talking about white and Black households with similar levels of income, but their neighborhood environments and the realities and choices that provides are very different. And what's striking to me is then when you look at the high income households, you look at the high income white households, only 7% of white households with income 75K or up live in, again, these high deprivation neighborhoods, where nearly half of the high income Black households live in these neighborhoods. And a lot of that has to do with these, you know, the history of segregation, the challenges of wealth building, and, you know, and you know, I think the historic explicit and the ongoing informal implicit forms of segregation that persist today. But this is another example where, yes, we need to talk about poverty, but we need to recognize that racism has effects, you know, well above and beyond poverty. A couple more things to share, and then I'd love to, you know, we'll turn more to the discussion of, okay, what do we do about this? You know, we've talked a lot about eating healthy, and I think someone, and sorry, I couldn't catch the name because the screen's so small with the pictures, you asked the question about education, and I think education is part of it, but I think, as Candyce said, I think the bigger issue is the access to choices. And so this is other data from the survey I mentioned, where it's interesting, where you asked people how important eating healthy was really striking to me is that Black adults in our region were more, you know, significantly more likely to say eating healthy is important, which I think is an indication that it's something people recognize and understand is important. It's something they want to be able to do. You see the 66% of Black adults say eating healthy is important compared to 52% of white adults. But then when you look at what percent actually report that they say that their eating habits are excellent or very good, that flips around. Now all of a sudden, despite the higher intention and interest in eating healthy, only 31% of Black adults say that their eating habits are you know, excellent or very good, whereas a much higher proportion, 43% of the white. And that gap it needs to be understood through the lens of barriers, access to choice, in being able to make that intention a reality. And so I do think education is a piece of it, but the issues are much bigger than education. I think the barriers to access and the reality of limited choice is the bigger factors. Yeah, I'm going to just quickly share this in the interest of time, but I think a path, this is a model that we find very helpful in starting to think about what you do about these health outcomes we have. So we've got tons of data, and I've only shared the tip of the iceberg in terms of the health metrics we have. But when we really look backwards to see, okay, what's driving these, we know that health behaviors are really important, but you can't, and it's critical that you can't think about or talk about health behaviors without framing them in the context of the living conditions that people face, because the living conditions really both frame the set of choices that people have and also provide the context in which they're able to make those choices. And again, I'll refer back to what I shared earlier about when you're when 110% of your mind and energy is focused on getting through the week and just having enough food for your family for the week and making it to your job on time, you're not focused on, okay, how am I saving money and plotting out my food budget so that we can stretch fruits and vegetables that are barely affordable across the next month. I mean, it's both the set of choices and the context for making short versus long-term choices that drive the health behaviors. And really, living conditions are those are a result of structural and social inequities. That's policy, that's politics, that's the way companies run, the choices they make. That's where the big leverage is in affecting the outcomes. And just to paint an example of what this looks like, again, in the example of diet and nutrition, and I think we've already hit on a lot of these, but you think about how do those upstream, those structural inequities impact diet and health. Discrimination in hiring and employment practices means if you're Black or brown, you're less likely to have a high-paying job. And I didn't even share the data there, but there's a lot of data. I expect folks on this call understand that there remains today a lot of discrimination in employment practices. That leads to lower incomes. And as we've said, buying healthy food is expensive. We talked about racial segregation concentrates the Black community in these under-resourced neighborhoods that are less likely to have grocery stores and more likely to be what we call food swamps. So that every corner's got the corner store, the fast food restaurant, as Candyce was talking about. A lot of that is driven by business practices, the companies, decisions they choose to make, and public policies that make that both possible and in some ways encourage that. Also, there's a bunch of interesting research that shows how unhealthy food is disproportionately targeted towards the programming, both TV and radio, of that people of color tune into. So part of the reason it's just part of the culture is not just because it's on the corner where you live, but if you're Black and living in a city, you're more likely to see those advertisements in what you watch, what you listen to, and on the billboards that you walk by. We talked about public transportation, and I think we could have a whole separate conversation about the way the government nutrition programs work or don't. But these are the structural factors that lead to less healthy eating, that then lead to the higher rates of diabetes, hypertension, and obesity that we see. The last thing, and this is shifting gears a little, but I know Candyce, you had mentioned this when you reached out to Dr. Clark originally, thinking specifically about how racism impacts healthcare and actually just the engagement between people of color in the healthcare system. And I'm going to call out a few things here, but I'd encourage Reverend Johnson, you, or frankly, any on the call to add to this. But there's a long history of mistreatment of Black people by the health, by the healthcare system, and probably the most well-known example of this, which still comes up when we do interviews with folks, is the Tuskegee study of untreated syphilis, where researchers intentionally did not treat Black patients with syphilis. They intentionally kept them in this painful, dangerous situation, withholding care just to see what would happen. And this was done presumably, maybe part because of the belief, as Reverend Johnson said, that science used to suggest that Black people didn't feel pain in the same way as white people. I think there's layers of racism behind this, but that is still fresh in a lot of folks' minds when they think about whether or not they want to engage with the healthcare system. And a national study a few years ago, that's the statistic at the bottom here, nearly a quarter of Black adults avoid seeking care because they anticipate discrimination when they go. And so it's not just that research shows that Black patients are less likely to get quality care. I mentioned that before, and I'll restate it here. It's that Black patients are also, just because of the history, because they know they're less likely to get quality care, they're less likely to even go, which of course has its own ripple effects on health. And a lot of these statistics are national, but Dr. Amina Alio locally did research about 8 years ago, specifically with the U of R, and found that nearly a third of Black patients said they experienced discrimination while receiving care. So this is not a thing of the past. It persists today and remains a real problem.
Mark, just an interesting comment to add on to that. I just returned from visiting my niece, who's down at Fort Bragg in North Carolina in the Army. And I asked her, how is the vaccination thing going? Because she's a captain in the Army. And she said, it's an interesting dilemma. She said, most of the white people are vaccinated completely. She said, mostly Black and some brown are very hesitant. And these are soldiers from all over the country. And they're still hesitant to get vaccinated. And this is the US government.
Yeah, I think that if we think about it, like Marc said, just even in terms of the Tuskegee experiment that they did, they promised these people, they promised these men, these were all men that they took and, said, hey, you have syphilis, we're gonna give you treatment for it, right? We're gonna give you a vaccine that's supposed to stop the syphilis. Please enter this study. And they told these men that they were gonna receive health care. Their health care was gonna be free. The drug treatment was gonna be free. And then they gave them all placebos, just placebos. And they noticed that the men were not getting better, they were dying. And instead of saying, the government stepping in to say, hey, you know what, this is wrong, they allowed the researchers to continue their research through the death of these men. These men were still sleeping with their wives, passing it on, like they were infecting other people, thinking that they were getting free healthcare. They weren't getting any kind of healthcare. So when you think about people of color not wanting to get the vaccine, because we've been experimented on in every kind of way for so long, even when they first started talking about a vaccine for COVID, they were testing it in the one area at the time that had the least amount of cases of COVID, and that was Africa. It didn't even originate in Africa, but you're going to test it in Africa where there's barely any cases. Now, of course, it has widely spread in Africa, but almost everybody that I know of that was a person of color, when we were listening to the news and we started hearing them saying, oh, we're going to test it in Africa, our first thought was, why would you test it on the Black people? Why do we always have to be the experiment for, or the guinea pig for the government. And that is what people still think. Monroe County has asked healthcare providers like human services organizations to call their clients based on zip code, because obviously they're under vaccinated. They want us to call our clients to offer them the COVID vaccine. And we had to, like, I had a deep conversation with my organization to say, listen, I know y'all don't know the history and y'all don't understand why this could be detrimental to or harmful to the relationship between us as a provider and our clients, but I don't feel comfortable just allowing anybody to call and try to convince these people to get vaccines, because some of these older people have lived through an era where we were guinea pigs for a lot of things. And that's fresh in their mind. If you call up any of my older relatives, they're going to be like, no, we're not getting the vaccine. We don't trust it. They're not experimenting on me. After everybody's taken it and we find out nobody's died, maybe we'll take it. And that is the mindset of some of these people that I have to call. They're like, no, you're not experimenting on us. Please don't call us anymore. So it's more the reason why African Americans, people of color, are afraid or resistant to getting the COVID vaccine or participating in any clinical trials, is because we've voluntarily done it before and involuntarily just been lied to and, undertreated just for the sake of finding out how it affects Black people. So.
What was that syphilis? When did that happen?
That actually, I'll tell you in 2 seconds. It
was in the 30s, 1930s.
Wow.
Experiment. It wasn't that far. Wasn't that far long ago. It was it was conducted between 1932 and 1972. So it ran for a very long time.
Wow.
Yeah.
That's actually a really powerful segue, because whether we're talking about the syphilis experiments of Tuskegee, or we're talking about the hysterectomies of Mississippi, or even Black physicians, or the Black female physician was allowed to die painfully during COVID, that issue of trust is still prevalent in the Black community. And so I think that's a good point for us to really start some discussion on what we can do. But let me at least put this in a national context as far as where Rochester is concerned. And I've been trying to scream and cry to everyone that will listen that this really isn't normal. A couple of years ago, because of the issues with the Rochester City School District, a distinguished educator was assigned to look over our educational system. And after an intense look at what's going on in the educational system, something really interesting was brought out. The distinguished educator said, after looking at Rochester City schools, I've discovered this, that Rochester is rated amongst the very top in terms of early childhood curriculums, near the top nationally. But then noted that Rochester is rated and ranked near the bottom nationally for Black male graduation rates. They start out near the top, and by the time graduation hits in the city of Rochester, near the bottom nationally. Something's not normal that's going on here. It's also a really, really curious thing when we look at housing. Rochester is surrounded by rich communities nationally. But do you know that Rochester is rated as one of the 10 most segregated cities in the entire country? That's inclusive of Mississippi. That's inclusive of Alabama. That's inclusive of Georgia. Inside of New York State, Rochester is rated as one of the top 10 segregated cities in the entire country. That blows my mind. So that tells us that there is a lot of work that needs to be done here. We're in a crisis mode. And of course, COVID has really shined the light on that. So what do you do in terms of a crisis? You ask yourself 3 questions. Always ask yourself what, so what, now what? And this is going towards some of Gary's comments earlier. We've been dealing a lot with the what in the data that we've been sharing, and the so what, because what we're living through in Rochester isn't normal, and we have to do something about it. But what is it that we should do? Next slide. It's a very interesting comment. Ibram X. Kendi said, individual behaviors can shape the success of individuals, but policies determine the success of groups. That there's a lot of work we can do on an individual level. There's a lot of day-to-days that we could and we should be doing, but we can't neglect the obligation of working at the policy level. If we really want those sinking ships to rise with the next tide, we have to look at the policies. Wonderful book, How to Be an Anti-Racist. And it says this, in essence, for all of us, that if we really want to move the needle, it is not simply the racists in society that allow this to perpetuate itself, but it's the lack of anti-racists. It's the lack of individuals willing to stand up and challenge systems. I don't know who it was earlier that made this poignant point. It really isn't about who's mayor or who's county executive. It's about the policies they represent. And we have to find ways to deal with issues in a way that survives the person sitting in a particular seat. And so I invite us all to look at the various policies. We have a call to action. And I'm going to share these 5, and I want us to have some conversation because hopefully you've learned a few things from us today, but we really want to learn some things from you. So here are five calls to action that we've declared. We'll support existing community initiatives to dismantle structural and institutional racism. There's a lot going on with Common Ground Health. You'll see that report in just a little bit. The Urban League is doing so much, and now we've taken over Reggie, and now we have Interrupt Racism as a movement that we're doing. Certainly the Black Agenda Group is doing so much in the city of Rochester, and we don't all have to reinvent the wheel. We can come together and really lend our voice to these common initiatives. Number 2, engage the leaders of your individual organizations and your community in dialogue about racism and its impact on health. Disclaimer, and I mean this from the bottom of my heart, I'm so tired of talking about race. I'm just sick of it. I hate talking about it. I wish we'd get to the point where we didn't have to talk about this anymore, but don't allow it to die. We have to keep it forefront so that we can change the relative positions of our citizens in the city of Rochester. We're all tired, but we have to keep running that race. Number 3, develop and assess all health improvement interventions through a racial equity lens. That issue that Marc talked about, the Dome Arena, not that it was a bad solution, it just wasn't looked at through a racial equity lens. So we have to ask ourselves, is this solution are we looking at this through the lenses of the least of these? Are we looking at this through the lenses of those who don't have great voice? Or am I only looking at this through my individual lens? So look through a racial equity lens. Number 4, promote business practices and policies to ensure there are more Black doctors, more Black nurses, more Black mental health agencies. If you have individuals in these systems that are working, they're talking every day, they're dealing with issues, not just with the patient, but with coworkers, it really does help to move that needle. I actually, because I had nothing more to do in my free time, I started a mental health clinic with a friend of mine who is a licensed clinical social worker, because there is an issue with Black and brown individuals seeking mental health solutions. Some of that eerily related to the same reasons why we don't seek certain healthcare, don't want to take vaccines for COVID. We don't seek mental health. There are stigmas related to prior racial bias. And so we're trying to do something about that. Number 5, we ought to all advocate for racial equity in our everyday lives, all of our actions, all of our conversations. If you see something, say something, object to those things that are wrong, affirm those things that are right. There's nothing more than what we've been taught all of our lives. And I think if we do that, we get on the pathway to at least opening ourselves to further dialogue. Now, the last slide is just simply Frederick Douglass affirming that disease is cured by the right use of remedies. It's not enough to have a solution, but how do we actually apply them? So Marc, if you can go back to the calls to action just for a second, I want to open this up for any of you to have some further dialogue. And Gary, I'd love for you to repeat your question, because we have to wrestle with, here are 5 calls to action, but what's missed? What's between the lines and the commas and the spaces that we haven't talked about? This might look good in print, but is it applicable in a way that we can really drive dialogue and bring about systemic change? And I'll pause now.
Reverend, just the thought in number 3, I think it's 3. The looking health improvement and looking through a racial equity lens. I can't help but think that so many of our government leaders, both locally, statewide, federally, they're white old men. They don't have the foggiest idea what a racial equity lens is. And they're making decisions for everybody. How do you change that?
Yeah, and I think if I can solve that one, I probably could also solve world hunger too. But I think it is true that individuals know what they know, and we always tend to go toward the familiar. And so I think we have to look at fair representation. What are the number of African Americans in the country? What are the number of Latinx individuals in the country? What are the number of white individuals in the country? Does our Senate and House of Representatives represent that? Does it look like that? If it doesn't, then that means there's a lot of education that needs to go on in communities prior to election years. There's a lot that we need to do. I'll say this, and I'll maybe Marc might have some more statistics on this, but I would say this: one of the great problems in our fair city is that we respond to everything in episodic fashion. We show up to churches when we're going to get elected. We show up to neighborhoods when there's a big disease. We talk to communities when we need some more help and some research, but we are not there absent any crisis, absent any major need. And so distrust will always exist where there's no familiarity with the other side. So we have to find a way to be familiar by being present.
So what I'm hearing is that we're a reactionary kind of community instead of a proactive community.
Yes.
That point is, we've said that in our own organization and I've been saying it for 15 years. The only way something happens is when there's a crisis. When we try to pull people together, and I don't want to take up an hour of time here, telling you about all the situations that we had for incredible potential that fell apart because people couldn't get along, or they were a different denomination, or because they had political aspirations one way or the other. And I'm going to have to jump off the call at 1. But I would hope that maybe we could meet again on Zoom before the end of the week and bring a list of things that we think could add to the cure here, and how we could begin pulling people together behind this effort to put some strength behind it. And the other thing, before I forget, was Reverend Johnson, is your church in the old Grace United Methodist Church?
Yes, that's the building.
Okay. So if you find a box up there that has some Project Urge stuff in it, that has the ABCD handbook for, asset-based community development. We had the office upstairs, that little office down the hall just before you get to the sanctuary area. So, we had some ideas going there, and it was because some people weren't getting along and didn't pull their weight. We had some fantastic ideas that were brewing in that neighborhood that I'd love to talk to you about. That, and I also want you to say hello to Phyllis for me.
Which Phyllis?
Phyllis Jackson.
Oh, absolutely. And I'll look for that. I'll look for that box. So much has happened during the course of all the renovations, but I'm going to look for the Project Urge box.
It's so long ago. It may not be there.
Yeah, but we welcome, and I'll say that for both my church, but also for Common Ground Health. We welcome that partnership, and certainly Marc can provide a lot of the data that would support some of our thoughts and drive the discussion. So that would be so great. I think if we stop working in this silo fashion, we can do something. So thank you, and I welcome us talking about that later in the week.
So could we set up a Zoom time for later this week? Just if we get together, say for an hour, and bring some ideas, some tangible ideas to the table.
We who, Gary? The whole
People
bunch of
on
us?
this call and any other people that you think would like to join us.
I certainly would. I would, just out of respect for not having to change it a million times, I would love to be able to look at my calendar first so I can make sure that we can do that. But I don't want to drop that. I want us to definitely have that dialogue in a time we have ample time to really do a deep dive. Yes.
And
So
in
I
the
can just get
interest,
that today.
I think we actually, before I have to go, I also want to say this was an excellent presentation,
Mhm.
and I'm going to tell as many people as I can to view it on our website or on our Facebook page. And I really think this is incredible. And I think we're going to be amazed when we get back together to see what ideas have been percolating but couldn't get off the ground. And we won't voice why that is here, but there's some real challenges, and I believe we have the potential to confront them and do something about it.
Thank you. We'll do that. And again, that credit goes to Marc Solomon for all the great work he did with providing this data and the direction for presenting this. So thank you, Marc, for that.
So one of the things, in the interest of not reinventing the wheel, and Pastor, like you said, there are already initiatives going on, and you mentioned a bunch of them, but I don't have them in my head. So, I'd really like to, I don't know, have that in writing or something, so that we don't want to go off as Project Urge necessarily and be starting some brand new thing that somebody else has already started. It'd be better if we could join forces. I think we're probably all in agreement about that.
I agree. And I'd also say, Cindy, that Project Urge should do some real thinking about what's in your wheelhouse. One of the dangers is when we try to be all things to all people. And so start thinking in terms of, well, would our efforts be better suited in terms of bringing nutrition to various areas? Would it be better suited in terms of pushing political levers? Would it be better suited with providing data to neighborhoods? So think about what the strength of Project Urge is, and then I think it would be great for us to say, okay, let's see in what area we can work together.
Okay. I do have a comment or maybe a question about number 5, about the phrase racial equity. And I was listening to a podcast by a public health person, expert of some sort, and he was talking about just like with our kids, what we do for one kid might not be what we do for the other. We're trying to do what's right for both of them. And to me, when I read racial equity, I think, oh, we want to do equal stuff for both the races. But yeah, so you're shaking your head, Mark. That's not what you meant, right?
That's precisely what equity is not.
Yeah.
Okay. Okay.
So we want to, and I'll give it to you, Mark, but always think about this. Equity literally means giving the person what that person needs.
Right.
And you raise an excellent example. Two children, they have different needs. And so you may have to give one kid a little bit more nurture in certain ways, because that's what that kid needs. You may have to be a little bit more of a disciplinarian with the other one, because that's what it needs. So when we look in Black and brown communities compared to the white counterparts, it's not enough to say give everyone $20,000.
Right.
If you don't have financial literacy courses to go with that, if you don't have the ability to talk to banks and put your money in the right banks and get loans in the right places, then that's not really equity. So thanks for raising that, because equality, and I think Mark chose the words very carefully, equality is not what we're after. Equity is.
Okay.
Mark, you want to say some more about that?
I don't know that I don't know that I could add anything, but it's funny as we're sifting through the material for today. I excluded a slide that specifically talked to that, and for the sake of sparing you an even longer presentation. But I think your point is critical, and a reminder that that's I think something that's really important to emphasize. So thanks.
Yeah.
I see that
Candyce,
chat.
can you unmute Latricia?
Yep, I'm about to right now. I was just going to say Latricia has a comment. She unmuted.
Good.
Latricia, go ahead.
Okay. Oh, thank you, Reverend Johnson. You really hit upon what my comment was going to be. I was trying to understand, where does financial literacy fall in this? Because as we're hearing poverty being one of the root causes, and I think I've heard you say a few times in other speeches or talks in regards to we pay people to be poor. And as we're making incremental gains, if our spending habits or just the financial literacy part, throwing money at a situation, they're still not, Black and brown people are not making gains. It was kind of striking in one of the slides I think Mark had of that even with the upper income, where they still choose to live with limited resources. So does that tie into the financial literacy?
Great question. I think it does. So I've often said that we tend to pay people to be poor or to remain poor. And so there's generational poverty because we at times tend to focus so much on income that we take our eyes off of wealth. And so most individuals that have succeeded economically in life have done so because they've increased their relative wealth status. And so without understanding how to handle income, your wealth remains relatively the same. So let me give you an example. So one person makes $50,000 a year, and that person buys a home that costs $100,000. Another person makes $100,000 a year and buys a home for $150,000. So income is different there. But in terms of wealth, they both have the same equity in their home. Not much different. Financial literacy begins to tell individuals that the interest rates make sense. Where you buy your home makes sense. It literally forces you to see that if I can't buy the home I want, if I can't get the interest rate I deserve, then there's something inherently broken in the system. And it gives you the ability then to challenge systems at its root. And so when we tend to only try to give individuals in a home, any home. So I developed low-income housing on the corner of Hudson Avenue and Avenue D. And we say, wow, we've done a great job. Now that person has a roof. But have we done anything to move that relative wealth status for that person? No, you're paying them to remain poor. And so we have to find a way to say, no, how do you get adequate housing, but housing that will afford you to move your economic status in life? So thank you for that question. But I think we have to be careful because well-doers sometimes pay people to remain in their same relative state. And we have to move them beyond that.
Mhm. And that also, I think that's true for maybe not as many white people, but certainly a lot of white people are not financially literate. I heard a statistic, something like half of the people that win the lottery go bankrupt within a year, some crazy thing like that. So money by itself is not a solution unless people know what to do with it.
Right. So Cindy, that's so powerful. And I'll say this quickly because our time is running out. Many of these things in and of themselves are not the racial portion. It's how it's affected when you put everything together.
Yeah.
Rochester was once this booming city and everyone that wanted a job had a job. Eastman Kodak was at its height. Individuals would work and they would retire until Kodak and Xerox and others did not keep up with the digital age, did not keep up with the technological age. And when everyone was laid off or fired or terminated, you saw the inequities then because their white counterparts were part of skilled labor, were part of managed labor. And so they could move away and get another job or stay locally, get another job or have enough skill to start their own companies. But Black and brown folks who worked made money sometimes as much as their other counterparts sometimes. But when jobs were lost, they could not pivot, they could not reproduce themselves because inequity during that crisis then showed up. So I'm agreeing with you there. These things affect us all, but in the midst of a crisis, we see that divide grow greater.
Yeah, right.
One suggestion, especially if there's interest in a follow-up conversation, we could send links to to some of the information about what else is going on. So, I mean, I'm Reverend, I'm thinking of some of the great work Urban League is doing with Interrupt Racism. And we could send some more information from Common Ground Health. I'm also, I don't know if folks are familiar with the recommendations out of the RAISE report. I'll admit I don't know the status of what's happening there, but there was, I think, some good thinking behind that. And to this point of not reinventing the wheel, I think it's great to understand what already has some traction in the community, what's already been discussed, and how can Project Urge either plug into or support those things. Maybe we can send some links afterwards with that.
Yeah, that'd be great.
And Candice, I'd say to you that we certainly make available to those here that if you wanted to join us on our African American Coalition calls, as we kind of wrestle through some of these things and strategies, you'll get a chance to hear our work plan and what we're trying to get done through the year. You would certainly be welcome to that as well.
Thank you.
Is that just Candice?
I was gonna funnel some information so it can be shared, but everyone's welcome.
Thank you.
Thank you.
So
thanks for challenging me on that.
We didn't nail down a tentative regroup time. Do we want to do that, or do you just want to Candice issue forth a command and we'll be there?
Well, no, I want to make sure that Reverend Johnson can work it through his calendar and that it works for everybody else. So his request was to let him look at his calendar first. So if you want to just email, we can work it out through email. And when we have a quorum, then we can say that's a date. Yes, is that acceptable for everybody?
Yeah, that sounds good.
Good.
Thanks so much for that. Yeah.
Yes. Well, it is 1 o'clock, people. And I want to thank you, Marc and Reverend Johnson, for being here, for doing your presentation. I think it was very educational.
Great stuff.
Information that we needed to hear. Very helpful, very useful. And the call to action items, we are going to actually try and meet up again later on in the upcoming week to make sure that we have a solid plan or can put a skeleton plan together or, find out where we best fit and can best support. So that is very, very welcomed and very helpful for us. Thank you very much. I see that there's emails being put in the chat. So if people want to take a second to copy down the email addresses for everyone that is there in the chat so that we can keep good communication, that would be greatly appreciated. But that concludes our time today. So once again, I want to say thank you. I would like for us to close in a word of prayer the same way that we opened. Anybody want to close us in prayer? Anybody? Anybody? John, you're pretty good at closing in prayer. You want to close in prayer?
Sure.
Thank you.
Dear precious and loving God, we thank you. We come this day, this beautiful Saturday, and carved out a few minutes of our time, and we thank you for this wonderful dialogue that we had today. We thank you for Reverend Johnson and Marc to help us see some of these things that maybe we haven't been seeing and that we need to see and need to acknowledge and know about. And Lord, we just thank you for being who you are and being such an important part of our lives. For you are the Alpha and the Omega. Lord, we thank you for this gathering of people. Be with all of us as we depart and come together whenever we can do it again. All these things we ask in the blessed name of your Son, our Lord and Savior, Jesus the Christ. Amen.
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 So much.
Before you go, can I do a little commercial for our next Diversity Cafe? And I mean
Yeah.
little. It's going to be in a month on a Saturday. It's the third Saturdays. Is that right, Candice? Crazy me. Yes, third Saturdays. But one of the topics we want to tackle in the coming months is how to engage in a conversation, a dialogue that's constructive with people who believe emphatically the exact opposite that we believe. It was kind of born out of an idea from Cindy that during the election, everybody was squarely on one side and not the other, and never the twain shall meet. And God help us if we meet on social media, because that's all the worse. But there are ways to dialogue with people that you are that you hold a strongly opposing view, hearing them, honoring them, and disarming the situation. And we just need tools to do that, because all I can think of now after my time with you is I'm going to be such a burr under the saddle of the people around me, because I will not shut up about anything that I've learned. So hopefully I'll be gracious and loving about it, but you can't be a gracious and loving burr, can you? I don't know. I would like to be better at hearing people and also exchanging information in a way that disarms and doesn't confront. So hopefully we'll tackle that at some point and give us some tools to carry the torch forth.
So Melody, what are you saying that we're going to do that next Diversity Cafe? Or
I did not say that at all.
Oh,
I said it's coming soon.
oh,
As
oh
in-
okay. I was going to
as-
say it's not one. It's